Today, we had a new patient join us, Tatiana, a young woman of 24 years old. She came in complaining of persistent back pain, which she described as sometimes unbearable, like severe muscle cramps. She works in an office and occasionally engages in physical activities like dance, which could be contributing to the strain. After dancing, she doesn't feel worse. In fact, she describes a pleasant kind of soreness. However, due to long breaks between sessions, her muscles are no longer conditioned for regular load. Tatiana brought along her medical documents, including an X-ray report showing a second-degree scoliosis in the thoracic spine, with a rightward deviation at the level of the third thoracic vertebra measuring 15 degrees. There's also a leftward deviation in the lumbar region. No signs of spondylolisthesis were noted. Her doctors had recommended physiotherapy, massage, and independent therapeutic exercises. Now, this is where we have to be honest. Independent therapeutic exercise isn't really effective unless you know exactly what you're doing. Most people, including Tatiana, simply don't. She's a logistics professional, not a trained kinesiologist. Watching videos online isn't enough. In her case, with S-shaped scoliosis, the approach must be very specific and supervised. Incorrect loads can do more harm than good. Symmetrical loading should come first, followed by asymmetrical work, and then we cycle back. Our goal is to reduce the severity and strain of the curvature. She also had a wrist fracture back in 2024 from a snowboarding accident. The cast was removed in March, and she followed up with rehab, resistance bands, massage, and therapeutic movement. There's some clicking in the joint, but no pain. Next, I illustrated her spinal curve, rightward in the thoracic and leftward in the lumbar. We strengthened the right side of the thoracic area and the left side of the lumbar region. And while this might seem counterintuitive to some, it's based on biomechanics. We stretch the overloaded side and strengthen the underactive side. Many non-specialists get this wrong. Standing under axial load, we visually confirmed what the X-rays showed. There's a clear curvature in both thoracic and lumbar areas, visible by asymmetry in the shoulder blades and spine alignment. Palpation showed tension, especially in the rhomboid muscles. Rotation and lateral bending tests confirmed limited range and discomfort on one side. We moved to the treatment table. Palpation of the lumbar region revealed shortened and tense muscles, particularly the quadratus lumborum. She felt discomfort, but not sharp pain. I performed a warm-up massage to release superficial tension. Her muscles responded well. We proceeded with neural mobilization, stretching and joint decompression techniques. Gentle manipulation of the thoracic spine helped reduce tightness. I used controlled pressure to mobilize the vertebrae. Her spine was quite mobile due to hypermobility, which can sometimes be mistaken for instability. We did thoracic and lumbar mobilization from both sides and proceeded to seated thoracic decompression. Next, we performed cervical spine stretches and a traction maneuver to relieve cranial tension. the end of the session, we checked for improvements in spinal mobility. Rotation, lateral bending, and neck movements became easier. She said she felt much lighter, with a noticeable sense of ease and better posture. Her back felt released, as if a load had been lifted. Tatiana left the session relaxed, surprised by how effective the treatment was. But, as I often remind viewers, the effects are temporary unless reinforced through therapeutic exercise and proper follow-up. This includes strengthening programs and sometimes physiotherapy. Manual therapy is not a one-time fix. It's part of a structured recovery plan. Thank you for joining us today. Don't forget to subscribe, like, and leave your questions in the comments. We'll be happy to answer them. See you in the next video.